The major problem we were dealing with during the OWL project was a question of supply and demand. There was far too much demand on our health service in the orthopaedic area, and the question of supply was around the number of suitable clinicians available to actually deal with the patients being referred in. So we took part in an initial pilot project funded by the Health Department and the Centre for Rheumatic Diseases, and it was around looking at clinicians other than doctors who could potentially deal with some of these patients that were referred in a safe manner, and by doing that actually alleviate some of the pressure on the system in terms of waiting list times and numbers in our region in Geelong and certainly in the other pilot sites. And for us in Geelong, this was part of a broader project about looking at expanding workforce roles to better cope with demand. Certainly that was one of our major challenges, was actually gaining the confidence of surgeons and other doctors already involved in the process so that they trusted what we were doing and could see that it was actually safe, and we weren't there to undermine them or their authority. It was actually about giving patients the best care in a timely fashion. The other issue that certainly arose, as it does in most public hospitals, is the financial pressures of introducing a new service, and also then the physical pressures of, if you want to put more people through a service, you have to have the space to deal with them. And those issues basically came down to being able to work within the existing system and with the various departments involved in the process to actually make sure that the project didn't set up more problems than it actually solved. And I guess for us the key thing was, from day one, because we already had an existing reform process, we could drop this new project in and that was fine, but we had to involve all of the relevant stakeholders, so both administrators, executives, middle management, clinicians, and also specialists like surgeons and various other doctors. There was also the issue around, do you have suitable clinicians to come in and actually do this work? And in many respects we were fortunate in that our existing workforce had reasonably experienced staff who were ready to take the next step. So in terms of just being able to develop the concept of the service and then have people on the ground ready to run with it, we were actually quite fortunate that we had existing staff who could, with the minimum of training, actually step up into a more responsible role than what they'd been doing previously. And therefore we didn't have any time lags between sort of the concept of this project, getting it all signed off and approved by the various committees involved, to actually starting to do the work, which was the whole point of what we were aiming for. The other thing for the staff who do the day-to-day work has certainly been that projects like this offer, I guess, a beacon of hope in some respects, that that there are opportunities to progress their career within the profession. Sometimes in some areas of health there's a bit of a glass ceiling effect. You can only go so far, and that's as high as your career will ever go. You then have to leave and go into the private sector or into tertiary education to progress your career. And projects like this and being able to create new positions out of them has actually allowed us to give sort of junior staff and I guess middle level staff a glimpse into what's possible if you continue to work your way up the ladder and get further qualifications and then put your hand up to be involved in some of these more challenging projects. This project and some of its forerunners did raise the question around if physios were upskilled even further to perhaps prescribe medications or inject medications, would that in fact provide an even better service? And the consensus certainly within the profession is yes, that would be a better service, but at present the law doesn't allow us to do that. And certainly I think, given the challenges we had early on with convincing the medical staff that the basic clinics we were going to run would be very safe, we would in many respects have to overcome those same hurdles again if we were to try and extend the scope of practice even further. Now, I mean, that's something that work's going on behind the scenes at state and federal government level, and that's not something we can directly influence, but it certainly has ramifications down the track if and when the law is changed to allow not just physiotherapists but other allied health professions to do what has traditionally been medical work, there'll be a whole lot of implications and ramifications for all the professions concerned, as well as the obvious legitimate concerns that will be raised by doctors and surgeons about whether people are qualified to actually do that work. I guess the other leadership lesson that came out of it for us was, if the concept appears sound in theory, then, as with most clinical staff who have any sort of science background, if you can back it up with some sort of research, some sort of evidence, then your chances of actually convincing people that change is necessary and or good improve. So a lot of our work was done in the early days just around, seeking out work that had been done overseas and around Australia to actually back up the concept that change is not necessarily a bad thing, and to support the idea that it wasn't change for change's sake. It was change for the benefit of, the system, the patients and the clinicians involved.
The Rural Collaborative